Hi friends, today we are going to discuss very important topic in MRCS orthopedic question answers. The topic of the day is fracture neck of femur. Fracture neck of femur is a part of hip fracture and most of the MCQs they are coming from this topic. First we start with the anatomy of the proximal femur. Here we can see the part of acetabulum, head of femur, neck of femur, trochanteric area, subtrochanteric area, and shaft of femur. There are two divisions of this proximal femur, intracapsular and extracapsular. Intracapsular includes head and neck, and extracapsular includes trochanteric and subtrochanteric area. We can further see the types of fracture involving the neck of femur. It can be subcapital, mid-cervical, and basicervical. Just below the head is subcapital. In the mid of the neck is transcervical or mid-cervical, and at the base is basicervical. And the trochanteric area, any fracture involving the trochanteric area is called subtrochanteric fracture or intertrochanteric fracture. And the fracture just below the lesser trough in within the 5 centimeter area is called subtrochanteric fracture. Here we can see easily the intracapsular fracture is in the mid of the neck of the femur, and this is the trochanteric area, and it's called intertrochanteric fracture. And within 5 centimeter of the lesser trochanteric area is a subtrochanteric fracture. So we can easily identify intracapsular and extracapsular hip fracture. Fracture neck of femur is the classification. To classify the fracture neck of femur is called Gordon classification. It has 4 is impacted or incomplete fracture. Type 2 is complete fracture but undisplaced. Type 3 is complete fracture but less than 50% displacement. And type 4 is complete fracture and displacement is more than 50%. You can see here impacted, undisplaced, mildly displaced, and completely displaced fracture. And the next hip fracture, as we discussed, extracapsular intertrochanteric fracture femur. We also call it peritrochanteric fracture or subtrochanteric fracture and trochanteric fracture as well. Here is extracapsular fracture, intertrochanteric, undisplaced. And here the picture of the subtrochanteric fracture femur just below the lesser trochanteric area. The blood supply of the neck of femur fracture is very important. It's coming from the medial circumflex femoral artery, branch of the femoral artery. What are the causes of the fracture neck of femur? Most common causes of fracture neck of femur is road traffic accident and fall, and pathological fracture could be due to malignancy or osteoporosis. Management of fracture neck of femur is tricky. It's a little bit difficult and depends upon age and mobility and comorbidities, and the age varies according to the different countries. We will discuss in detail. So just we can see this picture. It will help us in the management of fracture neck of femur, and this will be sufficient to give the answers for MCQs and MRCS. So here we are going to discuss management intracapsular fracture neck of femur. It could be undisplaced. So in this case, we are going to do cannulated screw fixation. It could be closed or open, and don't consider it. At any age, we are going to do cannulated screw fixation in undisplaced intracapsular fracture femur. If the fracture is displaced, what we'll do, if the patient is less than 50 years, go for, give the chance of fixation with the cannulated screws. If the patient is less than 65 years and has no comorbidities, go for total hip replacement. And if the patient is more than 65 with comorbidities, then we'll go for hemiarthroplasty. Before taking the decision of the surgeries in neck of femur, let's see this. We should consider how active was the patient, what about the mobility of the patient, and what about the comorbidities of the patient, because this takes the change the decision of the management. Like if we see the patient is more than 65 years and he is active, mobile, like doctor, teacher, engineer, and sportsman, we are going to do total hip replacement. If the patient is more than uh, 65 years and has osteoarthritis only, we'll go for total hip replacement. If a patient is more than 65 years and has osteoarthritis and as well as medical comorbidities like diabetes, hypertension, ischemic heart disease, cardiac surgery, then we are going to do only hemiarthroplasty. So now the management picture is clear in front of us. We will discuss few MCQs. Just I will change the age and type of fracture and the options. Everything is going to be clear. So the scenario I made is the 50 years old male, teacher by profession, presented in accident emergency with a history of slip and fall early morning today in the washroom with the complaint of pain right hip and inability to bear weight. Examination revealed tenderness right hip, external rotated right lower limb with intact neurovascular status. Radiological survey revealed garden type 2 fracture, neck of femur. So what will be our best plan of action? So we will get option A, total hip replacement, B, hemiarthroplasty, C, close reduction and K-wire fixation, D, plaster application and discharge, E, close versus open reduction and internal fixation. So in this scenario, we can see it is a 50 years old male, profession is teacher, and type 2 garden fracture. So in this fracture, it is undisplaced fracture as we discussed according to the classification. Age is 50 years. So we are not going for the total hip replacement. We cannot go for the hemiarthroplasty, and we don't do fixation with K-wires, and it's not applicable plaster in this age. So without the best option will be close versus open reduction and internal fixation. So this can be a with different types. So I made another scenario. In this scenario, everything is the same, but we change the option E to cannulated screw fixation. So if they give you option of open reduction or close reduction internal fixation, go for this option. If they give you option of cannulated screw fixation, so then you click for the cannulated screw fixation. However, the age, profession, and type of fracture is same. So just I changed the age in the third scenario. So we went for the 60 years old male and we kept the same garden type 2 fracture and we kept all the options same like scenario 1. In this scenario, see the garden type 2 is there and 60-year-old, there's a patient is active and mobile. So we have to give chance of fixation. So we'll go for close versus open reduction with cannulated screws. So let's go for the another scenario. Here I have a age of 65 years, active male, and type 3 garden fracture. So patient is active, age is 65, and he's teacher. And the fracture is displaced. So we have the option of total hip replacement, hemiarthroplasty, close reduction and K-wire fixation, plaster application and discharge, close versus open reduction internal fixation. So the fracture type is type 3. So it is displaced fracture, but patient is active. So the best option will be total hip replacement. We don't go for hemiarthroplasty. We cannot do fixation with wire and plaster and with the screws. The same patient, same presentation, just I added ischemic heart disease and diabetes. So in this scenario, even the garden type 2 fracture, but we cannot take the risk. So here we will go for hemiarthroplasty because the chances of complications are high in comorbidities. So better to go for one surgery. So we will go for hemiarthroplasty. Now we go for the extracapsular fracture. This is intertrochanteric fracture femur. Very easy. We kept the patient 65 years old male, same teacher by profession, and we did only the radiological survey. There's no difference in the presentation of the fracture neck of femur and intertrochanteric fracture femur. So X-ray revealed the X-ray findings are displaced in intertrochanteric fracture femur. So what will be our best plan in this case? So I give the option of total hip replacement, hemiarthroplasty, close reduction and KY fixation, plaster application and discharge, and E close versus open reduction and internal fixation. In case of intertrochanteric fracture femur, we have the option to fix it. It could be close versus open reduction internal fixation. So we cannot go for total hip replacement here. We cannot do hemiarthroplasty in this case, and it's not recommended plaster and KY fixation in intertrochanteric fracture femur. The best option will be close versus open reduction and internal fixation. It could be with the different types. So if they give you option of gamma nail in intertrochanteric fracture femur, could be displaced or undisplaced, we have to click for the gamma nail. In the past, we had an option of fixation of intertrochanteric fracture femur. It could be displaced or undisplaced with dynamic hip screw. So if the option is dynamic hip screw, so go for dynamic hip screw. If there's an option of open reduction internal fixation with plate in the screw, go for that option. And if there is an option of gamma nail, go for gamma nail. The all option, they cannot be together, so one of them will be there. So just go for that one. This total hip replacement, hemiarthroplasty, plaster application, any other option, they are not for the extracapsular fixation of fracture. The last one, the subtrochanteric fracture femur, that is the extracapsular fracture femur, is within the 5 centimeter of the lesser trough. In this case, the scenario I kept the same, and only the radiological finding will be changed. That is subtrochanteric fracture femur. So in this case, we are not going to do hemiarthroplasty. We will not do KY fixation. We will not do plaster application and discharge. We cannot do open reduction and internal fixation. Yeah, this could be the option, but the best option here, the option is intramedullary nailing. If there is no intramedullary nailing in this option, then we can go for close versus open reduction and internal fixation. So this the answer in the subtrochanteric fracture femur, best option is intramedullary nailing. This fracture, the fracture neck of femur and intertrochanteric fracture femur, they are also seen in the children. In this case, we have the option same in the children. We have to preserve the neck as much as possible. So we will go for close versus open reduction internal fixation. Could be with the screws, could be with the small DHS, could be with another plate. So I hope this tutorial will be helpful for you in solving your MCQs, and